You should not be assaulted at work. It's not part of your job. It's not accepted. To your earlier question, which you opened the interview with around this quote about violence never being acceptable, that can be true. It can also be true that there are contextual factors that might impair a person's ability to form reasoned decisions. And they react or they act in ways that are dangerous to us. They're hazardous to our health and safety. And we need to take steps to ensure that we're safe and also that the patient is safe. And those systems might fail. They might actually assault a paramedic because they have a cognitive impairment like dementia. We did training on that in Peel Region about how to recognize expressions that could lead to violence among people who have cognitive impairments like dementia because they're just not in a right frame of mind. I think different. Their brain chemistry is different. The solution from a justice perspective isn't to toss this person in a prison. And I don't think most paramedics want that.
The violence against paramedics is never okay. What does that mean to you, Justin?
It means that we shouldn't be tolerating this from an organizational standpoint. You shouldn't be going to work and expecting to be subjected to verbal abuse. So my colleague who you brought up earlier, Mandy Johnston, put this beautifully in a poster that we brought to the OAPC a little while ago. She had a picture of like an office worker, right? Like somebody working in a bank, and then they're sitting behind a desk, and there's a person, like a client, like a customer or whatever, that's just unloading this stream of expletives on this. We're saying it's not acceptable here. And then the next picture is a paramedic with a stretcher and the same person spewing the same stream of expletives, which, by the way, were taken from some of our violence reports. And we say it's not okay here either. And so it's not an acceptable part of the job, with the caveat that it might not always be preventable. And there might be mitigating circumstances that contribute to why this happens. But that doesn't mean that we're going to condone this and say that if you're a paramedic, this is part of your job and you just need to learn to deal with it. No, absolutely not.
I got to know, was there a personal experience that was the impetus to lead to you to all this research and all your contributions?
For me, no. For Mandy, she was really galvanized to start doing this work and getting that ball rolling in Peel Region, 5 years or so now, out of a couple of pretty significant personal experiences. Not my story to tell. What got me into this is when Mandy asked me to contribute to this from a research perspective, and then looking at the research that had been done in Canada and some Sentinel research back in 2014 by Blair Bigham, that identified that this was a problem. Paramedics were experiencing violence, they're not reporting it. Strikes me as odd because occupational exposure to violence is really high risk. There's a risk of physical injury. There's a significant risk we're seeing now, we have the data to back this up, of psychological harm from these. So how can it be the case that it's so casually dismissed as part of the job? And really importantly, if it's not being tracked, it's not being reported, we can't mitigate that. We can't work upstream for that. So that's kind of why I got into this. As a researcher, I like to dial in on process and dig into the data and understand an issue and then generate data that turns into actionable risk intelligence that leads to meaningful change. And that's what we're doing.
So if we talk about the meaningful change, how do you measure that? Like, what's your barometer to say this is an acceptable amount of change to ensure paramedic safety?
Well, first, let's get them documenting it, right? You can't change where you can't measure is problem priority number one. So go back to Blair Bigham's study in 2014. He surveyed paramedics in Ontario and Nova Scotia. He found that something like 75% of them had experienced different forms of violence in the past year, but less than 20 or 40% of them had either documented the incident at all or reported them to supervisors or police. And that's really important because if we're not documenting these incidents and starting to identify trends, identify commonalities, we can't work upstream from them and try and implement risk mitigation procedures. So step one of change is figure out a way to measure it. And to do that, we needed to identify the barriers. Why aren't people bringing these incidents forward? Why aren't they reporting them? What are the barriers? Some of them are administrative and other ones are organizational, cultural. And we spent quite a bit of time on understanding that organizational culture and then working within it to change it. And we're starting to see that show up in the data now. So when we started this, we didn't have a process to document incidents of violence. We were coming up against headwinds that were stigmatizing reporting, this whole part of the job BS. And that meant that we weren't capturing it. So we did a bunch of things, and I'm sure we're going to get into it. But fast forward a few years later, we went from less than 40% reporting to more than 80% reporting. It's more than doubled. There's your change. One dimension of change.
What do you think the bottom 20% that's still not reporting? What do you think are the barriers in place for that subset of the population?
When we asked our people again, we surveyed them again after using our reporting process and all the things that we've done in Peel Region to try and change this culture about, what influences their decision to file a report or not. We see that it hinges on their perception of volitionality, so whether the violence is intended to cause harm, their perception of severity, how serious the incident is. Those things are very much in the eye of the beholder. They're more inclined to not report something that they don't see as either intended to harm or being of high likelihood to cause harm. That's part of it. Another big part of it, the part that's more modifiable from our end on a service perspective, is whether the report is likely to lead to meaningful change. They don't want to fill out paperwork for paperwork's sake. They want to document something so that they know that that information, the data in that report, are being used in different ways to support business cases for new equipment, to establish an interoperability working group that strengthens our relationship with our regional police partners, that's being used to document potentially traumatic exposures to the paramedic to support, workers' comp claims, to provide follow-up care, and to work upstream and identify high-risk incidents in the future. Those are the receipts that we're able to bring, and that's, I think, the big driver of the change in the uptick in reporting.
So if I hear you correctly, that just the culture of Peel Region, 100% is for this project, and from management to paramedics. And of course, like you said, people don't want to report things if there isn't going to be a result out of it because you're just adding work with no value. So you look at this holistically and think about, hey, how can we solve these problems, but also predict these problems so it doesn't happen to paramedics and everyone's involved in that process?
I like how you framed it, work with no value. Right, that's the big thing. They're more inclined to fill out the paperwork. We put this reporting process together to keep the administrative burden really low, but they're more inclined to do that if they see it being used for things. And increasingly, with some exceptions, I'm hesitant to paint the entire workforce in our service or elsewhere with one broad brush, but increasingly they are seeing value in that. The work does have value. It does translate into actual actions. Training, another big one that came up as a direct result of the research that we were able to do in Peel Region from the data we were able to gather. So you start to see this cause and effect. I fill out the report goes in, it gets aggregated, it gets piled, and it's used to do things like give me this super intense 12 hours of high fidelity simulation-based training that we did on violence prevention recently.
I know these are anecdotes, but how many times do fellow paramedics come up to you and talk about how happy they are to see results come from this reporting or from this training?
I'm not one of the instructors for the training. I'm not on the road a ton. I'm mostly back of house. So I don't get people coming up to me per se. I get feedback in the types of research that we do. A really good example, we're in the middle right now of a really comprehensive mental health study on paramedics, post-pandemic mental health in Ontario, multiple services. It replicates some work that we did before the pandemic, where we looked at the prevalence of PTSD and related things. This is sensitive stuff. It means the paramedics had to fill out a survey that had symptom questionnaires, self-report screening tools for things like PTSD, alcohol consumption, depression, suicidal ideation, really, really personal stuff. And for some of these people in the current study that we're doing, they could do it anonymously or they could do it confidentially. And so they knew they were putting their name down. And then we would send them a report that characterized their risk level on each of the DSM-5 screens we use. We try and connect them with care. Part of that is we went and surveyed them again to ask them if that was helpful. And the feedback that we got in that follow-up survey is heartwarming, man. Like, that's the whole reason I do this stuff. Some people said to me, I thought I was doing fine. I saw the report. I realized maybe I was struggling with something. And I went and I talked to a psychologist, and now I'm going to therapy and I've got a diagnosis and I'm getting help, and I'm finally paying attention to these issues that were piling up in the background that I just couldn't see. And the part that really is heartwarming for me is where they say, I'm telling other people to do the same. So if you want the anecdotes person to person, Mandy's a great person to talk to about that. The instructors for our violence prevention training. We also have a peer champions program for violence prevention in our service where people spread the word informally and help people fill out reports. They get amazing feedback on just how well received that is, but it's not my story to tell.
If we linger on the heartwarming part, because I think that's such a salient point, why is it so heartwarming to you when paramedics say these things?
Because it's more than the system. It's about trying to do some good on an individual level for individual people. I've been in this profession for coming up on 20 years. It's going to be 20 years next month, which breaks my brain a little bit to think about it. I'm a second generation paramedic. I followed my mother's footsteps. She was a paramedic in the city of Toronto for years, at a time when there weren't a lot of women working in the profession, at a time when there certainly weren't a lot of women single mothers working in the profession. And the work, to be frank, took an enormous toll on her physical health, on her mental health. She's not on the road. She's disabled from this profession. And it's very much, at least part of the motivation is just trying to make things better, both on an organizational level to say, can we draw attention to some issues and then resource these problems better? But also where I can, and I'm not always able to, but where I can, to give individual people through research the opportunity to experience benefits. The mental health study is a great example of that.
I think that's so rewarding that you're truly looking at the system changes or trying to implement system changes and remove these barriers. But then you have this strong core motivation thinking about your mom and fellow colleagues who've said these pretty deep things. And we want to commend you for this work. Do you have any other personal motivators that have made you realize like this has to be addressed and we shouldn't normalize paramedics feeling this way or feeling disenfranchised on the road or getting assaulted?
Well, I mean, there's my TED Talks. I mean, I wasn't originally studying this. My background's in education. So my undergraduate degree, my master's degree were on education. I taught the community college level for several years. That's where kind of my first love was around, how do we teach paramedics better, especially when we use simulated learning environments? How do we recreate good, realistic simulated learning environments? I wasn't doing mental health research when I started out my PhD, and I would bump into people who just assumed, because it was in the news a lot, that there were high rates of PTSD, there were high rates of suicide among first responders and paramedics. And they would ask me, they say, aren't you studying, PTSD prevention or something? And my response was always the same: super important, right? But there's an army of people that are doing this research and really high quality research. And it wasn't until our service had two of our senior, well-respected, well-liked members die by suicide in the span of something like 6 or 7 months, that my employer, the paramedic service in the region of Peel, asked me to do a data analysis study on some qualitative data they gathered from a survey from a consultant, that the consultant had come in and just kind of done a bit of a job and then left. And when I was doing that work, I started to dig into the research, and I realized that my assumption of an army of people doing really important, really high quality research on paramedic mental health wasn't true. There wasn't a lot of research. It was really early days. When there was research, we're rolled in under the umbrella of public safety personnel, which is useful, but we have very significant, I think, between branch differences that set us apart from corrections, from fire, from police. And I don't see those differences being explored because they impact mental health, they impact help-seeking behavior, they impact the organizational culture, and they need to be, and other people weren't doing that. So that's why I saw an opportunity to come in and do some good quality work.
How did that ripple? Like, because that's kind of interesting that people just assumed you were involved in this research, but it's such a niche kind of avenue. But how did this like ripple into all this? So you started finding this data, then it led to you just being like, oh, I just want to explore this more because this is a needed field that we have to uncover.
Well, how far down the weeds do you want to get on this one?
Let's go down the weeds.
There's a really good study done by researchers that are affiliated with an organization called the Canadian Institute of Public Safety Research and Treatment. Huge organization, came out of a federal funding mandate from Public Safety Canada to address high rates of post-traumatic stress disorder among what the government calls public safety personnel. That's us, right? So that's RCMP, municipal police, provincial police, security and intelligence officers, Coast Guard. Coast Guard might be CAF, don't quote me on that. But we're under this umbrella and it's needed. And so these folks, researchers affiliated with CIPCERT, did a national survey, and they asked public safety personnel from across the country to fill out these screening tools to get an idea of just how prevalent symptoms of PTSD, depression, anxiety, disturbed sleep, a whole host of health problems are. They have maybe 500-600 something paramedics from across Canada. But when you put out a survey like that and you put it on the internet, you don't have a lot of control over who's filling it out, who's enrolling, who this is appealing to, whether they meet your inclusion criteria, which is super important for really good research. And the survey itself, it took something like an hour to fill out. 40% of people-ish, depending on the paper you read from it, didn't actually finish it. And so in my mind, that cast a lot of uncertainty around the scope of this problem. And so my first research study that formed the foundation of my PhD was to go into this space and say, let's tighten this up, right? Let's focus on one paramedic service because we can get almost if not, as many, if not more paramedics from one paramedic service than they got from the entire country. And let's make sure we're being really dialed in about who is participating so that we can have more precise estimates of how severe this problem was. And that's what I did before the COVID-19 pandemic. And that was really my first meaningful study in this area.
Incredible. How has that landscape changed post COVID-19 pandemic, or has it changed?
For paramedic mental health?
Yeah.
Well, we're doing that now. In 2019 to 20, when we studied our folks in Peel region, we found that 1 in 4 of our active duty paramedics screened positive for current symptoms of either post-traumatic stress disorder, major depressive disorder, generalized anxiety disorder. 7% indicated some form of suicidal ideation within the past 14 days. We had a 97% response rate, so we're really confident that those prevalence estimates were reflective of our workforce. And the really important note there is we didn't ask people if they were diagnosed. We asked them if they were experiencing symptoms. And these screening tools are not diagnostic. It's not a one-to-one, but it's close. It's pretty close. Like if we took one of these folks and put them in front of a psychologist and they disclosed the same symptoms, there's a reasonable likelihood that that person would walk away with a diagnosis and hopefully a treatment plan, and that's probably not the case. 25% up to February 2020 was pretty significant. We're just in the middle of doing this again. Same approach, multiple services this time. PTSD has remained pretty consistent. We were 8 to 11%, depending on how you score it. Pre-COVID, we're about 12% now. But depression is much higher. Depression went from about 15% to 27%. Depending on the service. Anxiety went from 15% to 23%. Insomnia is really high. It's nearly 1 in 3 people who have symptoms that would be considered, clinically significant of insomnia. We have other indicators that point to fatigue as being a really big problem. There are increases in these symptoms because Public Health Canada, StatsCan, they do population level surveillance of these same indicators using the same scales that we do. And they found that during the pandemic, there were increases in all of these. And so we've seen an increase that is more or less in step with the increases that we saw in the general population. But it's worrisome. And the depression one in particular, really, I don't know what's driving that. And that one really worries me because, depression is something that I've struggled with in the past. Those symptoms suck. And they can pretend suicide.
To make that operational, because that's such a staggering numbers to comprehend. And I'm just thinking about underreporting and where the true numbers lie. But if you think, like you said, 25% of paramedics screened had symptoms of PTSD.
Pre-COVID, for any of PTSD, depression, or anxiety, about 8 PTSD. Post-COVID, 36%.
And just thinking like the average crew members at an urban base and urban service, like if you look and there's 8 people in that room, you start doing numbers in your head and you're like, wow, that is eye-opening. And then also like, if people aren't aware of those numbers, do you find there's a reluctance to believe that many of your coworkers could be suffering with those pathologies? Or do we just kind of put a blind eye to it naturally because we're just so used to coming to work?
I didn't believe them at first when the research studies that I was telling you about from the group that worked with SIPCERT came out. Their estimates were way higher. 1 in 2 paramedics screening positive for a mental disorder. I looked at those and maybe I fell into the same cognitive bias trap. I was incredulous. Like, that can't be true. That's insane. Those numbers are really high. And so that's why I wanted to put a finer point, really dial in our participant selection and recruitment to get more precise estimates. So it's tough because on the one hand, I'm relieved. I'm like, oh, okay, our rates are less than half what these other researchers have found. That's great. But they're still a lot higher than population. PTSD is on average, 3 to 4% higher. Depression is in some cases almost double. Like, the rates are really, really high when you compare it to the population level. And so it's hard to wrap your head around in some cases. But I'm reminded of Paige Mason, Ottawa, a paramedic, recently did a master's thesis. She also looked at paramedic mental health, but she took kind of the complementary perspective. I've been approaching this from my perspective as an epidemiologist. What's the prevalence? What are the risk factors? Who bears the burden of disease? How do we mitigate it? Paige looked at people and recognized that, most aren't struggling. Most are doing well. And why is that the case? And then how do we tap into that from an organizational perspective to promote a culture of wellness and health? And so her work is equally important. It brings a different perspective.
I guess from a like systems level, did you see that that rise in PTSD or other like psychopathologies? Did those map onto like an increased number of staff that are off on like mental health leave or stress leave or things like that? Like obviously those things are going to contribute to burnout.
And both are pre-pandemic and then, 2024 studies. We didn't include people who were on leave. The rates would actually be higher. This was just people who are clinically certified, who are actively working on the trucks, providing paramedic service in our communities. 2019, it was 1 in 4. 2024, it's 1 in 3.
Yes, that's such a massive impact just on staffing levels.
I don't even want to say it. Imagine a workforce reduction if the people who had really severe symptoms needed to be off work. Reassuringly, for the people in the confidential stream that we sent reports to, and we tried to nudge them toward accessing care, and then we asked them if they did, a lot of them said they are receiving care. So that's reassuring. And because you might be experiencing symptoms of PTSD or depression, for example, it doesn't necessarily mean that you need to be off work. But, these can be really serious, really disruptive symptoms. And so, yeah, just imagine for a second the potential impact on our capability as a public service provider if we were to see a reduction in our workforce, even half the prevalence of these mental disorder symptoms that we found.
If we go deeper into that, because you made such a key point that just because you have those symptoms doesn't necessarily mean you need to be off, but what about the ones that should be off and aren't off? Like, how do we help support them? And then I'll follow up. The next question is, how does that impact patient care if they are feeling these symptoms too?
We have a good body of research and a lot of conventional wisdom probably that tells us that there's a lot of stigma around mental illness. That's perhaps more prevalent. It's for sure more prevalent within the public safety professions, especially when you look at our comparable branches like police and fire, where there's a culture of toughness. There has historically been this culture of suck it up. You don't portray vulnerability, for example. And so it's not good to ask for to admit fault or weakness, or what could be perceived as fault or weakness, even though that's not the case with mental illness. So there's cultural headwinds there to overcome this, that there is stigma attached to mental illness. But set that aside, we need to deal with it, certainly. The other part of the equation is access to care, access to trauma-informed, culturally competent care for public safety personnel broadly. And where I really get on a soapbox about this, for paramedics specifically, part of that is from funding, from having, say, for example, benefit coverage to go see psychotherapists, to engage in counseling, from being able to have streamlined access to mental health professionals. So we've started to address this in our service where I work in Peel Region with a new program that partners with one of our regional hospitals, Trillium Health Partners. And it started out as a pilot project, but our members get expedited access to mental health assessment and treatment within, say, 48 hours. Through these referral pathways, we can have a member undergo a really comprehensive psychological evaluation and start to get access to care. So we're trying to take out as many of these barriers as we can. Cost is a persistent one. And this isn't to think about individual paramedic services, but when you look at public safety personnel, our rates of, again, another umbrella term, post-traumatic stress injuries, which includes PTSD, but alongside things like depression, anxiety, burnout, suicidal ideation, all these other things, our rates of PTSI are really high. They're some of the highest among public safety personnel in the country, but our resourcing is much lower. Benefit coverage, health and wellness programs, we don't have in-house psychologists by and large, for example. You look at the kinds of resources that have been deployed in policing contexts, which are needed and probably quite effective, where they have entire facilities that are devoted to health and wellness, gyms, family rooms, in-house mental health professionals, huge programs. We're so new and we're so comparatively under-resourced that our rates are high, our funding's low. I don't know why,
Why do you think that is? Just It always seems like we slowly have the status quo till there's a couple of big events. Then it's people like you that look at everything and like, this doesn't make any sense. Like, our rates are this high, our coverage is this low. And no wonder we ended up where we are from a system level. Like, how did that slowly slip to this point?
I think a lot of it was masked by physical injuries. So think about, you fellows were around for a while, right? You remember lifting stretchers. I was in a training room the other day and I saw 35A or X or whatever it is. I'm looking at this thing and be like, oh, most of my career was picking these damn things up. I think to myself, how did we ever do this? Like, in what world were we expected to pick this piece of equipment off the floor, much less with a person on it, plus gear, and lift it into the ambulance? And then that was such an improvement over the 30 stretchers. What my mother, for example, started out, not even with the advent of being able to roll this in and lift up half of it, deadlifting this off the ground and putting it in there. The result of that is that we had these really high rates of physical musculoskeletal injuries that were career limiting. People didn't retire, for example, by and large, right? They injured out. And so as we've moved toward automation with assisted lifting devices, with no lift policies, with power lift, power and load stretchers, we're seeing longer careers. Amazing, thankfully. But I think it's unmasking a lot of this psychological trauma, psychological distress that was happening all along. It was reclassified or hidden.
I'm just thinking from an education side of things, and obviously I'm not trying to demean the education system, but do you think it could start more at the college side of things? Is like, how do I actually prepare you to see the things you're going to see and deal with the things you're going to see? Because I remember one of my mentors said this, who was a longtime professor, and he goes, can you imagine a 20-year-old has had one other job, and then they go right out and they're on their first call or first shift, or even if it's their 10th shift, they see a dead person that's relatively young or seeing a horrific accident, then they're like, go back to base, fill out your ACR and eat lunch. Like, what are we doing when we say that out loud? That's perspective, right?
There's a lot there. I agree with you that we need to rework the brochure a lot, right? So another part of my PhD research, for example, was looking at this idea of role identity, how people construct their sense of selves in relation to the social roles that they have, being a father, being a volunteer, being a mother, being a lawyer, being a paramedic. And the idea is that we construct a sense of self around fulfilling these roles and fulfilling them competently. And there's a mismatch. What I found in my PhD research was there's a mismatch between this concept of paramedic identity in terms of what we do and how the person identifies with it and what the job requires. And those circles don't overlap a whole lot when you put them in a Venn, which is really problematic. So that's the brochure piece. On the other side of this, there are good things that are generally protective for health that we should be doing, right? Not that I want to put emphasis on individual, because there are real structural issues at play here, but we want to control for as many things as we potentially can to stack the odds in our favor. So that's having really robust and well thought out social connections. That's eating healthy. That's getting good quality sleep. That's being physically fit. That's having a well-diversified sense of purpose and meaning. That's having hobbies. That's having good engagement with our communities. All these things help us as individuals to be resilient when we encounter adversity. On the service side, we also need things that are environmental, that allow us to have resiliency, access to mental health professionals, a good living wage. We're well compensated in the province, which is fantastic. Being physically protected from harm, having the opportunity to have a timeout after a really bad call. Those are organizational things that let us be resilient. So you have to think about this as person in environment. Both are really important. And then the last piece, which I'm really starting to dig into with the recent data we have, is just that even if we do all those things right, a lot of people won't catch PTSD. Amazing. That's perfect. And even if we do all those things right, some people will. They will be deeply and significantly affected by the work. And there's just a segment of risk. If this whole circle is risk attributable to paramedic work, to mental health and well-being, we try and control as much as we can. There's probably a slice that's residual that we can't eliminate, and we need to be upfront and clear about it, and we need to try and mitigate it organizationally and provide resources for people to support them as they navigate it. So it's a lot of layers there. Hopefully that helped a bit.
Yeah, correct me if I'm wrong. It's the Swiss cheese approach. So multiple holes in the Swiss cheese or the system issues lead to the effect. But if we can control the controllables and do whatever we can to lower the risk of PTSD and all those negative consequences, then that is probably the best leverage point we have in helping to protect these paramedics.
Let's control the things we can control, right? Exactly your point. Let's plug the holes that we can plug. I think what I'm saying is there might be some we can't. So let's plug as many as we can.